All right, well, we're going to get started on fluid volume and electrolytes. This is really fun, isn't it? So, fluid volume and electrolytes to me is one of the hardest things to learn in pathophys and pharmacology, any nursing course where this is brought in, because I think it just takes a lot of studying to really understand fluid volume and what kind of electrolytes are in our body and the different types of tissues. So I'm going to do the best I can to explain it on here, but when we're in class, we will talk a little bit more about it. And I also, I like pictures, and I'll be drawing pictures on the board and things like that. All right, I'm just trying to move my screen over just a little. All right, well, hopefully this will work. Okay, so let's think of homeostasis. What's homeostasis? That means not that foot that you see in the picture. That's not homeostasis. Think of it as being like a normal, your body's functioning the way that it should. Everything's even and balanced. So everything in your cells, everything outside of your cells is completely balanced. Your blood's flowing like it should. Potassium, magnesium, calcium, phosphorus, etc. is all where it should be and in the right balance. All right. So when we think about, we have all these tissues, so it gets kind of confusing. Like, how did this swelling come about in this lady's leg? So what I want you to think about is we have two compartments in our body. We have intracellular fluid. So think of a blood vessel and think of a cell, like a round cell. Intracellular fluid is everything in that cell. Extracellular fluid is outside of the cell. So think about all the other stuff that's out in your bloodstream. So that is extracellular fluid. So within the extracellular fluid, we have interstitial compartment, intervascular. So interstitial just means like it's like clear fluid plasma running through. Intervascular is like your actual blood going through. Now, this is how I like to think of it. I would actually take out transcellular compartment out of that, because to me, when you think of, you'll learn about third spacing, which I guess I'm going to teach you right now. You have intracellular, extracellular, and then you have this other place where these fluids go and they're not supposed to belong. All right, so that's your transcellular compartment. It actually like goes out, and you see these feet. Can you tell that's not supposed to be normal? So it leaked out into the extra tissue. Why did it do that? Well, your body was not in homeostasis for a variety of reasons and illnesses. Your electrolytes, one electrolyte goes off, it can throw off the other ones, because remember, inside the cell, outside the cell. Inside the cell has so much sodium, potassium, water, and so does outside the cell. But if one has too much, it's going to push it out. And it can go either way. The fluid from in the bloodstream can push into the cells and make the cells swell up. All right, so think of transcellular as just being that extra area that it's not supposed to go. Like, say people come in and they have extra fluid on their lungs. That's not normal. And also on the feet, that's called edema. So that kind of thing. Okay, sorry to stop, I had to sneeze. All right, so let's get where we were. Okay, I don't have a student demo. That was from the instructor last semester, so I'm just using her slides for this. All right, so let's move on now. And this is a very important slide. So when we think about replacing fluids, or how your actual homeostasis is supposed to be, this is a really good slide. What I want you to look at first are these three cells, actually three vessels here. So think of this round thing around here as like your blood vessel. You're just like looking in this tube. All right. Now, right here, isotonic. See how perfect it all looks? That's how it's supposed to be. So you have the right amount of water going in and the right amount of water going out, as well as it has the right amount of potassium and sodium in the cells versus outside the cells. So everything looks good. Then we have over here, hypertonic. What does that mean? Let's go over here to hypotonic first. So here's your cells. Now, do you see how they're more swollen than your isotonic? That means that more water has gone into your cells to swell them up. All right, so I think of hypo as like hippopotamus, like fat. So when you think of hypotonic, I think of the cells as being fat like a hippopotamus. So more water and more electrolytes are being pushed into the cells. So if you have low sodium in your blood, okay, one reason could be it's because all the sodium has been pushed into the cells and swelled the cells. So if you think of cerebral edema or swelling on the brain, that can a lot of times be these cells swelling up. So you have to be real careful about what kind of fluids that you're giving the patient. And this is where we're getting at, is the fluids. Now, hypertonic, that means that, think of the cells, have shrunk. So the cells have pushed whatever it had in there, water and other electrolytes, out into the extracellular space here. So if you have high potassium in your blood, one of the reasons could be because they moved out of the cells and now there's too much in your extracellular space, meaning it's floating around in your bloodstream. There's too much of it. So look at these three things. These things will help determine what kind of IV fluids you're going to give. We have isotonic IV fluids, we have hypotonic and hypertonic. So if somebody we determine let me just think of a thing we could do, like a low sodium. Let's say let's do sodium. If someone has a low sodium, that means it's low here, and so the cells may be swelled up. So you may want to go ahead and give a hypertonic solution to kind of off balance that, to pull some of that sodium out. So I'm going to go through hypertonic solutions, but one of them would be like your 0.45 normal saline. That means it's got half sodium in it. And then it would be the vice versa. So if they're hypertonic, you have so much and you want to pull electrolytes and water back into the cells to make them look isotonic again. That's when you're going to go for your hypotonic solutions, okay? Those would be like your 0.33. So it just depends. I'll go over that in class, though, and I have a list. I just want you to get the gist and understanding. Isotonic is always your 0.9 normal saline and your lactated ringers, or some people call it ringers lactate. So if somebody has diarrhea and they're just basically losing electrolytes through being sick or having the flu, or if they're going through surgery and you just want to keep them hydrated, that's when you do an isotonic, because their electrolytes may not be off. It may be in balance, but they're losing electrolytes through. So this whole plasma area is going to be decreased, but it's still going to be sort of in balance. I know it's a little bit confusing, but if you're just like, if you lose blood, if you lose potassium by diarrhea, or just water in general, you want to fill it back up with this isotonic solution. All right, so let's move on. We talked about homeostasis, and as we learned in the past, that we have diffusion, active transport, there's pressure. So when we think of pressure, think of the cell and think of the blood tissue outside the cell. Remember, we had that tube on the last slide, and then the cells were all in the tube. They are basically competing against each other. They're pushing on each other. The cells want to get out, and the fluid wants to get in. If things are off balance, one can move in, one can move out, or can even move out in that extra space. An easy way to remember is a 60-40-20 rule. You have 60% body water in the cells, you have 20% in the interstitial tissues out in the blood, and 20% is in that other compartment that we really don't need any more fluid. All right, so there's types of IV solutions, which we talked about. Another name is crystalloids. I rarely ever use that term, but isotonic is your 0.9 normal saline, and your lactated ringers. Sometimes they make D5W, that's sugar, into it could go isotonic either way, or it can be hypertonic. So when you think of hypertonic, if you think hypertonic solution, all of the sodium has been sucked out, so you're going to give a different. If someone's hypotonic and the cells are swelled, you're going to give a different solution, a less amount of sodium in it. All right, so then we have colloids, blood, and blood products, and lipids. So if you look here at the picture, we have blood, we have lipids. So lipids are fats. So if somebody's getting TPN, which is total parenteral nutrition, so someone's getting nutrition through a central line, they're going to be getting lipids. That comes in one bottle, and they're going to get the other fluid, which is all your electrolytes, and they put insulin in there and a whole bunch of stuff in there. How do we use these types of IV fluids? So there's a reason, or there's a method to how we pick IV fluids, as I mentioned before, but excessive fluid loss, diarrhea, maybe you're not drinking enough, maybe you're peeing too much, you have diabetes, if you're diabetic ketoacidosis, fluid loss, foot surgery, bacterial, all of those things. So you can read the slide and see that there's multiple reasons why we can lose fluid volume and electrolytes in our system. When you think electrolytes, you think your potassium, sodium, calcium, magnesium, phosphorus, etc. All right, now we have some volume expanders that sometimes can be used if someone is really profusely bleeding out. Dextran solutions, which is your people that are hypoglycemic, or I should say hypoglycemic, yes, and you'd give some dextran or dextrose. Albumin, people need that for healing, and there's a head of starch which helps with bleeding too, although I've never really dealt with that. We have blood, plasma, platelets, whole blood, packed red blood cells. I can guarantee you guys will be dealing with packed red blood cells and plasma, most possibly platelets. Not too much whole blood is given anymore. Then we have our lipid emulsion, which is that bottle with the white stuff in it. That's fat, because everybody needs fat. All right, so what happens if someone has a fluid imbalance? So you're going to identify your patients at risk for it, and then you need to do an assessment by checking their vitals, labs. Always note what baseline values are, because if they have labs every day, you can look to see if they're improving or not. And as far as nursing diagnosis, it's going to be their deficit in fluids, so fluid volume deficit or fluid volume overload in some other cases, but there's an imbalance in that. And then you would say the reason why, like inadequate fluid intake or excessive fluid or sodium intake. And then you have to do your planning. So this is your goal setting, remember? So the patient will exhibit balanced fluid volume, and the patient will have balanced intake output over a 24-hour period. That's a better goal, I think. Nursing interventions would be, you're going to give the amount of prescribed IV fluid. That's going to infuse hourly, depending on what the doctor orders. And then you're going to look now for signs, symptoms of fluid volume deficit, or you're going to look for signs of overload, because if someone has heart failure, think about it. Your heart's a muscle. If you have heart failure, your heart's failing. Your muscle is weak. It can't pump out all that fluid like us, like you young people. I can't say I'm totally young anymore. But what happens is you can get fluid overload. If you're giving someone IV fluids, your heart's not able to pump all that fluid. It can't keep up with it. Then you're going to do the evaluation. Are things better? Are they working? Is the things that you're giving them working? Okay. Now we're going to talk about electrolytes. I think it's easier if you learn fluids in general, like I just did, your isotonic, hypertonic, hypotonic first, and then understand all the electrolytes that make up the intracellular and extracellular space in the cells and out of the cells. So these are your major electrolytes: potassium, sodium, calcium, magnesium, chloride, phosphorus. Also, I recommend that you could stop the video right now and take a break and then move on when you're ready, because this is a little bit longer than I like it to be, 10-15 minute increments at the most, but I'm going to keep going on this one. This is just an overall showing what electrolytes do in the body, in the kidney. I know you have anatomy and physiology, I think, this semester, so I know you're going to be learning about this. You don't need to memorize this at all for this class. All I want you to know is to just kind of study it a little bit and notice how water comes out, sodium goes out, glucose goes out. So it's basically filtrating, overall filtrating all your electrolytes to make it balanced, to keep your body homeostatic, to keep it where it's supposed to go. And if, say, think of people with kidney failure, it maybe not function very well. That's why a lot of people with end-stage kidney failure need dialysis so it can do the job for them. So you will need to know normal ranges of potassium and all the other electrolytes, and I'll make sure we go through that. Potassium is 3.5 to 5.0, and it really has to do with, it has many functions, but muscle conduction is one of them. And there's such a thing as hypokalemia and hyperkalemia. So if it's hypo, low, cal is potassiumemia, is condition of or a problem. Hyperkalemia is too much calcium in your body. That's more than 5. So there's a lot of symptoms that you can have, but the main things with potassium deficiency or too much potassium is cardiac issues. It can be very, very dangerous if your potassium is too low or too high. So, for example, if it is, let's see, if it's too low, you can think of it being low, like you're feeling slow and low. You have decreased reflexes, decreased bowel sounds, your blood pressure's low, your pulse is weak. You sometimes, extreme cases can get confused, but you can have some EKG changes. And then whereas hyper, you're actually going to have symptoms of muscle weakness still, your urine production goes down, respiratory failure, muscle twitching, because potassium is responsible for nerve and muscle contractions. Okay, so like nerve conduction, muscle contraction. So think, if it's not working very well, then if it's hypo, you're going to have decreased reflexes. If it's hyper, you're going to have an increased reflexes. But impulse conduction, muscle contraction, what's the heart? That's a muscle. And so that can really wreak havoc on your heart and the electrical part of your heart. Okay, impulse and conduction. And we kind of talked about this a little bit too, the potassium deficit. So weakness, fatigue, irregular rate, tachycardia. Again, we'll talk more about this in class. We have hyperkalemia, the muscle twitches, because remember, you have too much, and if it's for nerve conduction, muscle contraction, you're going to have twitching because it's overactive. Similar to magnesium in a way, although hyperkalemia is much more dangerous with your heart. So you always have to think that with heart. And then as far as the nursing process, you're just going to assess them. You're going to do the signs and symptoms and see their potassium level and see what it is. Here's your nursing diagnoses. And you want the potassium level to go back into normal limits. So how are you going to treat this? Well, if somebody has, excuse me, low potassium, you're going to give oral potassium. If it's just mildly low, you can go ahead and do that. But number 1 and 2, you want to assess the patient and notify the doctor. So if somebody's low, that's what you're going to do. If it's really low, then you need to give some potassium through the IV. You have to be really careful because it can only be in an IV solution. You cannot give it IV push. sub-Q or IM, it's very dangerous and lethal. So it needs to be in a sufficient amount of saline in the IV bag, and it needs to be infused slowly. And you need to watch the IV site too. You want to monitor your potassium levels frequently, all electrolytes you do, because remember its purpose of it, and it's a fine balance, and so that can go out of whack pretty quickly. And monitor their EKG. All right, so let's talk about sodium, 135 to 145. Sodium, what does it do? It actually helps regulate the water inside and outside your cell. So think sodium and water love each other. They're in love, so they go together. So if you're losing water, it's moving, the sodium's going to go with it. All right, so if you have too much water and sodium in the cells, it's going to swell up, and then you're not going to have a lot of water and sodium outside the cells. So then we have hyponatremia and hypernatremia. And there's 3 reasons why you can have hyponatremia. One is euvolemic, hypovolemic, and hypervolemic. And I'm going to go over this in class, but euvolemic just means that you have water in the body, but increased sodium in the body. All of that stays the same, but the sodium is diluted. Let's just say that you have the right amount of sodium and you have the right amount of water in a glass. So you pour some salt in there, and that's normal. All right. What if you keep the same amount of water and you start adding more salt? Now what do you have? Because now you have more salt and the same amount of water because they're not working together. So now you have a hypernatremia. But how are you going to fix that? How can you fix that? You're going to fill it up with more water, right? So you can dilute it. Sometimes it can become over diluted. So that's how you can fix that balance. So you're going to give them IV fluids, right? Hypovolemic means like the patient's dehydrated, they've lost blood. So they've lost sodium and water. So usually that's from your vomiting, diarrhea, NG suction, water pills, excessive sweating. So you're losing both with hypovolemic hyponatremia. Think you're losing water, you're losing sodium. And then hypervolemic, so you have too much of both. Your sodium and your water increase. So now you're going to have volume overload. So what can cause that? Heart failure, kidney failure. If you had too much saline solution, that can move the fluids till you have too much, and liver failure. Usually if someone's euvolemic, that's the first one, remember their sodium increase. The water increases, but your sodium stays the same. That's usually because you have a hormone in your body called antidiuretic hormone, and that's actually a disease. So what happens is that specific hormone retains water in your body, and it dilutes the sodium. With adrenal insufficiency, Addison's disease, which is an adrenal insufficiency. Adrenal glands sit on top of each of your kidneys. There's one on each of your kidneys. And that has a major role in your body by excreting cortisol. And cortisol is what helps you basically function. And if somebody does not have enough cortisol in their body, your body doesn't make it, you can die from it. And so that's called Addison's disease. So you need to have cortisone every day. You don't need to know that for testing in this class, but it's good to know why you're doing what you're doing. Let's see what else we have here. Okay. Here's some slides on hyper and hypo. Think of salt loss for hypo. You're losing salt, so you can have seizures. Anybody below 128 is at risk for a seizure. It can be very dangerous. Abdominal cramping, tiredness, the reflexes are not working as well, and sometimes spasms of the muscles. So those are some of the reasons down here too, and for hyper and hyponatremia. Sodium, so you're going to do the nursing diagnoses. Obviously, you're going to check that and check the sodium level. And what is it for? Your nursing diagnosis is specific. What's it going to be from? All right. And what are your nursing interventions going to be? What do we do about this? So you're going to always watch their cardiac, respiratory, renal, GI status. If they're hypovolemic, then you want to give them some IV sodium solution, like a 3% saline hypertonic. Because remember, we want to pull that out of the cells into the extracellular compartment, which is like outside the cells. All right, this could be very hard on veins. I've rarely ever given 3% saline solution. So that's a hypertonic solution. If they're hypovolemic, then you're going to restrict their fluids because now they've got too much going on. Restrict their fluids because remember, think of that glass of water with the sodium in it. If you tell them they can only have like 3 glasses of water a day, hopefully that sodium and water in your body can balance out. And also foods, which we'll talk about in class, but it is bacon, butter, canned foods, cheese, hot dogs, all the bad things, but if they need the sodium, they need the sodium. All right, calcium. Calcium has to do also with like muscle and nerve conduction. It's less than 8.6 is hypocalcemia and more than 10. So 8.6 to 10.2 is normal calcium. If you have too much calcium, then you can have a hyperparathyroidism. Your thyroid's, in your neck. Your parathyroid is like a butterfly around each side. You got 4 areas of your parathyroid, 2 on one side of your thyroid and the other 2 on the other side. They actually control and regulate calcium. So if you have cancer or even bone metastasis, because remember there's calcium that helps keep your bones strong, then it could be a sign of that if your calcium's high. EKG changes also, and we'll go over the EKG in class. And as far as calcium, you always want to check their levels, nutritional imbalance, which saying that's why they maybe have a low calcium. If it's too much calcium, it's usually from other reasons, like the parathyroid issue. Or tissue integrity. If somebody has a low calcium or say a high calcium, it's more high calcium, you can have numbness and tingling of your hands. So this makes sense. Planning, nurse interventions. Now it says to monitor total calcium and ionized calcium levels. Ionized calcium is specifically the calcium that's floating around in your bloodstream, not within the cells. Okay, it's just it breaks it apart. How are you going to manage it? So there's some foods high in calcium and vitamin D. You need to watch for tetany, so it's muscle stiffening up like tetanus. That's why we have tetanus shot. I will watch for bleeding, the gums, mucus. You're going to watch your heart rate, and sometimes we have to give calcium gluconate. Always calcium needs to be in gluconate in order for it to infuse appropriately. Always watch the IV fluid. There's also a really cool sign for, it's not cool, well, it is kind of cool actually. To check for hypocalcemia, there's a Trousseau sign, a Schoesbeck sign. You tap on the inner ear, like right in front of the ear, and the other one is you inflate a blood pressure cuff, and if their thumb and their forefinger go together as you're inflating it, that's a Trousseau sign. That's a definite indicator, both those, for low calcium, so it can be dangerous. Then we have magnesium. Magnesium is muscle, so you're seeing a theme here, right? Muscle, nerve conduction for these electrolytes, body functions, bones, for calcium. 1.5 to 2.5 is normal, but too much of a good thing is a bad thing, so anything greater than 5 is panic. It's really hard to get really high magnesium. I don't see too much toxicity. If anything, we tend to run a little bit on the lower side. We like to keep people over 2, especially with heart issues, because of the muscle what it does for the muscle. Keeps it contracting very well. If you're going to have a high magnesium, as well as other electrolytes we talked about, it's a lot of times it's from renal failure. Because remember, you saw that renal tubule, and things are excreted and taken in, and it's balanced out with a normal kidney. If it's not, it's going to do what it wants to do. If you have too much, though, you basically feel like a lump on a log. You want to sleep all the time, and your reflexes are not there. So that is just a thing that needs to be watched for. But it's really, that part's really rare. Now, hypomagnesia is more common. Usually it's from malnutrition, malabsorption, people that drink a lot of alcohol. Sometimes people that are on loop diuretics, which is your Lasix, or thiazide diuretics, which is a hydrochlorothiazide or chlorthalidone. That's basically, it does not maintain your magnesium, so more can come out in your urine. It's like that with potassium too. Potassium, if you're taking Lasix or hydrochlorothiazide or those thiazide diuretics, it's not potassium sparing, so you can lose more potassium. So I have to watch labs with all these drugs. So I'm not going to read this. You guys can read this, and you can read this. Chloride, this is the range, 96 to 106. The functions of chloride. Chloride and sodium work together, so they love each other. So sodium and water, let's just say sodium, water, and chloride just love each other. Like if I'm going down, then I'm going down with you. Metabolic alkalosis from vomiting, loss of hydrochloride, they pretty much go together. So if you have any flu with elderly people, you have to really watch them. You don't see cystic fibrosis as much, but you have to be careful with their chloride levels. If you have a high chloride, remember it would be more with metabolic acidosis versus the other, metabolic alkalosis. So if you ingest excessive chloride, some diuretics, but I don't see that very much actually. You need to watch for sodium bicarb levels, which may lead to too much chloride. Then we have phosphorus, which is another electrolyte, 2.4 to 4.4. Let's go to this one. So again, the phosphate usually is responsible for working within your cells for energy, and it helps with muscles. So again, we got a lot with muscles here. Phosphate's regulated by your parathyroid hormone. In order for your parathyroid hormone to function, you need adequate vitamin D in your body and calcitonin, which is part of calcium. They all work together to determine the amount of calcium and phosphate that needs to be absorbed or deposited into the bones or your kidneys. So it's a finely tuned machine. If somebody does not believe in a God, I don't understand, because think about just this simple or intricate, detailed part of our body and how it works so like a well-oiled machine. It's just crazy. How did that come about? So I'm going to stop here, and then I'll talk more in class.